So tonight I'm going to go through some information on transient osteoporosis and specifically go over the Mayo Clinic experience. And Jod Sphere I see is on here as well. Jod was one of the authors on our paper here. So let me just see. So there's no disclosures. So we'll talk a little bit about what transient osteoporosis is and also review the clinical spectrum based on our experience, look at some risk factors that have been thought to be associated with this, and then we'll talk briefly about treatment. So transient osteoporosis is rare. I mean, nobody's seen a lot of cases of this, myself included. And it's characterized really by acute joint pain, most commonly the hip. And then very specifically, bone marrow edema is really a required diagnostic feature. And typically it's seen on MRI. Periarticular osteopenia can be seen, and then this typically will just resolve spontaneously over several months. Now, there's a couple things to think about. You should differentiate this from AVN, avascular necrosis, which is a much more debilitating condition, which may require surgery. And the other thing to think about is reflex sympathetic dystrophy, which usually has this burning pain and more cutaneous vasomotor signs, and it leads to more permanent long-term disability. With that being said, since it is a rare disease, there are a lot of questions regarding why does it occur, what are the risk factors, what are some of the associated features, how should you treat it? And so that was really what led us to look at this after we saw a case. One of our fellows, who's now at the University of Nebraska, spearheaded this. So the clinical presentation typically is going to be this sudden localized joint pain. And again, it is the hip most commonly. And some of the other terms that have been used to describe this in the literature are transient osteoporosis of the hip and acute bone marrow edema syndrome, just because of the radiologic imaging that's seen. And so here's kind of the classical MRI. This is one of our patients where you can see on this T2 weighted MRI, this classic bone marrow edema in the femur neck and the femur head. So in AVN, you're going to really see subchondral lucency, femoral head deformity, but this is a typical feature of transient osteoporosis. Now, the other feature that you can see is demineralization, and it's pretty clear on that same hip, the left hip, you can see less mineral compared to the right hip. But this can take several weeks, 3 weeks or longer before you would see this on a plain radiograph, whereas the MRI, you can actually see that bone marrow edema within 2 days after the symptoms begin. And if you do technetium bone scans, you'll see increased uptake, and this is the same patient where you have increased radiotracer uptake. And again, this can be early on that you can see this bone scan. And this can actually persist for several weeks, even after the symptoms get better. So for this particular study, what we did is it was a retrospective study, obviously. In this particular case, we looked at outpatient records seen at the Mayo Clinic. And one of the amazing things about being at the Mayo Clinic for clinicians is that we have records going back to patient number one. You know, at the Mayo Clinic, we have this huge medical record repository. Now, since we've had an EMR since around 1994, 5 kind of time frame, we're able to do this much easier now, but we still have all the old paper charts. So we looked at this essentially 15 years of patients, and we used we searched the terms transient osteoporosis, bone marrow edema, and migratory osteoporosis, and we found 45 patients. We had predefined inclusion criteria, and 33 of the subjects met our predefined, which really included acute onset joint pain, bone marrow edema on MRI. Some patients were excluded due to they had AVN, which is the most common thing that you'll want to think about. And then we also, just based on literature, we preemptively decided we wanted to look at some different things in the charts as we look through these patients. So we looked at bone density, looked at any evidence of sudden limb overuse. We looked for any evidence on the lab testing of bone and mineral disorders, smoking more than 10 cigarettes per day, previous transient osteoporosis episode, pregnancy, which is really where the first cases were described back in the 1950s, I think, alcohol consumption that's excessive, oral glucocorticoid use, and then we looked at low and high BMIs. And so cutting right to the data, of our 33 subjects, there were more men than women. We had 61% were men and the other 39% were women. You can see that they were certainly not lean, which would be, kind of our Midwest cohort. When you looked at time to symptoms to diagnosis, it was really around 2 months on the average, which was a little bit shorter than most other reports. So there had been one report that said maybe 1 month was when they presented after the symptoms, but this is actually a pretty short time course. And we think it's just because we do more MRIs, probably we picked this up earlier, and especially with that criteria for the diagnosis is why we saw that. From the time from diagnosis to symptom resolution was a mean of 4 months. And some patients will go over had more than one transient osteoporosis episode, and that actually had an average between those two episodes of 36 months. Oops. So as was previously shown in the literature, most of our cases were in the hips, but we did have knee and ankle cases. Because it was really part of our inclusion criteria, it shouldn't be surprised that everybody had pain at the affected site. And really one of the features is that weight bearing was in all of the patients was a problem, and they had quite limited mobility for symptoms. And for signs, the other thing I'll point out is they had quite a limitation in range of motion as well. Gait was often altered, and they had some local tenderness. But I think it's really this acute onset of pain, trouble weight bearing, and limited mobility that may raise the question of this diagnosis. When we looked at risk factors, we did 16 of the subjects had, of those 33 subjects actually had bone mineral density of the spine and hips. And in 81% of those patients, they had at least one site where it was low. Bone density was predefined criteria were low. And I'll just say that the sudden limb overuse was seen in a third of our patients, but this was much more prevalent in men than women. And so in a man who maybe had that exposure to, activity, that may be a precipitating factor in men more so than women. When we looked at laboratories, we're going to hear about vitamin D, and probably a lot of people have vitamin D that's low that may be unrelated. But we did see that 75% of the patients who had labs performed had some kind of abnormality in a bone mineral marker, such as low vitamin D, idiopathic hypercalciuria. One patient had hypophosphatemia that really wasn't well evaluated. We had one patient with osteogenesis imperfecta of all things. Smoking was seen in a quarter of the cohort, and actually a third of the patients had one previous episode of TO either before or after they were seen here with us. Pregnancy, which is kind of the classical association, was only seen in 6% of patients. Alcohol excess wasn't a predominant feature, and we didn't see anybody with low BMI, but on our defined criteria, about a quarter had high BMI, and oral glucocorticoids again weren't a real predominant feature. And so when you look at the top 5 risk factors, really low BMD was common, followed by sudden limb overuse, especially in men. Many people will have some abnormalities, and I'll cover more about other markers of bone metabolism, and then smoking, and then previous TO episodes. So these would be kind of the things you'd want to key in on if you're suspecting that. And I'll just say that nearly 80% of the patients had at least one possible risk factor for transient osteoporosis. When you look at laboratories, calcium was normal in everybody it was measured. Bone turnover markers classically are normal in this condition. That includes bone alkaline phosphatase, except a patient with CKD where that isn't unexpected. Bone resorption markers are completely normal. And maybe it's just because of there's only a small area of bone involved. I don't know if I quite understand that. Parathyroid levels were normal in all 5 patients it was measured in. So management, in this cohort, what we found was that these patients get better with really much with just time. And so the time from diagnosis, symptom resolution again was 4 months with a range of 1 to 18 months. But there were 4 patients who had more of a prolonged course of more than 1 year. Almost all of the patients were managed conservatively. They had complete recovery. And bisphosphonates were used in a small group of individuals. I'll cover the numbers here in a minute, but they had longer recovery time. But we thought that this was likely related to those patients who weren't responding to the usual measures. That's when they get referred, probably, and that's where we might try an IV bisphosphonate, thinking that it might offer benefit. There are some case reports suggesting these could be useful. So again, the conservative management predominantly was offloading and using crutches and analgesics, and that's really, those are going to be your workhorses for treatment, and then patient reassurance that these will resolve within a period of time with these conservative measures. Bisphosphonates were used in 7 patients. I don't recall quite why these surgical procedures were done, but there were a few who had surgery, and then calcitonin was given in just one individual. So I'll keep us on time today, I think. So summary of kind of what we've learned and how I'd look at TO. So transient osteoporosis is definitely a rare metabolic bone disorder. It affects middle-aged individuals in general, but men seem to be more predisposed to women, and it may be related in part to this higher sudden limb overuse that's reported in men. So, one feature I think that's worth remembering. Transient osteoporosis involves weight-bearing joints, most commonly the hips. So in a middle-aged male with acute onset hip pain who had overuse, you're going to be thinking about this. It's characterized by pain, trouble bearing weight on that affected side without any prior trauma. Earlier time from symptoms to diagnosis, likely in this cohort, we think is related to the increased use and availability of MRI, which is central to the diagnosis. Most patients have at least one risk factor, and when measured, bone density is often low, including sites not involved by transient osteoporosis, suggesting that there may be more of a generalized decrease in bone density than was previously recognized. Underlying abnormalities in bone and mineral tests are common when assessed, but bone turnover markers are normal, as is calcium and PTH. And then conservative management really is associated with resolution in most of the patients. So that's what I have.
All right, we do have time for questions. So if people want to type questions in the chat, or let me know that you're interested in asking your question, and I'll call on you.
I'm Dan Malone. I have a question.
Go ahead.
I think I probably know the answer to this, but this strikes me as a model by which we could figure out perhaps some ways to treat this disorder that we usually see, which is the more slow onset osteoporosis. Wouldn't it be great to be able to get osteoporosis to go away in 4 months if we could figure out? So my question is, what, if anything, do we know about the histology and physiology of this? Probably not much, I'm guessing.
Yeah, there are some reports on histology, and I'm trying to remember when we reviewed this for the paper, where I've seen reports with transiliac crests and biopsies and site biopsies, and there are some reports of increase in osteoclasts in those biopsy specimens, which is, I guess, a little bit disparate with the lack of bone turnover marker increase. But mainly what I recall is there were focal areas of resorption as well. But there is some literature on biopsy in those areas, and I don't think it's completely understood.
Thanks.
Rob, this is Joe. That was great, and it's really great that you guys put that series together, because it really does give us some insight as to how to manage them and what we can tell patients. There's this osteoporosis after pregnancy that has compression fractures and stuff. That really seems to be a very different kind of thing than this, isn't it?
Yeah, I think it is. I mean, obviously pregnancy can precipitate this, has been associated with TO, but this osteoporosis associated with pregnancy, I think, is different. Yeah, I think it's different. Yeah, I just leave it at that. It's usually more severe vertebral fractures.
Right.
And there, I think, it's most of the literature uses bisphosphonates, but the most recent reports suggest that maybe we should be using anabolic agents, PTH, And what I thought was really interesting in some recent literature out of Asia on that is that you don't need to follow those maybe with bisphosphonates. You just treat them and they don't seem to lose bone like in a postmenopausal woman. So I think this is different. I mean, this gets better with just offloading. So there's some kind of an acute inflammatory process locally, that causes this. But I think a lot of these focal bone disorders are pretty interesting. Fibrous dysplasia, Paget's, all these things have some different features.
Rob, this is Neil. It's really more of a comment, but it's kind of along the lines of what both Dan and Joe just raised. And my last patient with this had a 25% BMD increase at his hip when his osteoporosis resolved.
Right.
And that suggested to me that he could not possibly have had any sort of microarchitectural damage. And I wonder if the pregnancy condition is associated with the microarchitecture getting punched out, and transient osteoporosis is not. And sort of the caveat of that is, will trabecular bone score shed some light on this? And if we ever get the capability of measuring TBS at other sites, maybe that would be helpful too. So, if you guys have got DEXA scans on this series, hang on to them, and it may be that we'll be able to do TBS on them in the future to see if their architecture just stayed the same. They lost all the mineral and then they just put the mineral back in.
That's a good idea. Yeah. And I'm looking here, I was looking at our paper, the bone biopsies at the site of TO, they say invariably reported thin and sparse trabeculae with decreased interconnected arrangements. But so, I don't know. I think whatever happens really fast. It gets better really fast.
There's a question in here, Rob. Can you see it? It says, could it be misdiagnosed as bursitis?
No.
And have a good intra-articular response to intra-articular steroid.
No, because these patients, they have very characteristic radiographic and clinical presentations. I mean, that MRI is not bursitis, so it's really bone marrow edema. And so it shouldn't really, could it get misdiagnosed? I suppose it could. But when in the patients where it's going to be diagnosed definitively, you should have the radiographic findings.